My name is Tibor Fehér, and now I'd like you to move to a further direction towards psychology. I'm a clinical psychologist, not a medical doctor. However, I'd like to talk about the intersection of our fields. My vision is simple. I would like to imagine a patient care where GI problems would be better prevented, mitigated, and cured by a more psychosocial medicine. And my mission in this game would be the development of these psychosocial interventions and prevention programs. Now, we are going to talk about two separate projects here, the first being the prevalence study, and then the investigation of the risk factors. But I'd like to give you a quick background, because these psychological connections are not as easily understood, and let's meet halfway, my profession and yours. We already know that there is a bidirectional relationship between the brain, the gut, the microbiome, and the psychological variances. We already know that. We know that depression, for example, increases the risk of chronic diseases, and the other way around as well. We already know that chronic diseases, on the other hand, increases the risk of depression. Let's look at the case of IBD. We know the prevalence, 20%. The case of depression, 15%. But the problem is, and this is a very serious clinical problem, is that we do not have these same data for pancreatitis. In order to investigate, we used a COCO-POP framework with the clinical question, what is the prevalence of anxiety and depression in patients with pancreatitis? And of course, given our experiences at the ward, hence translational medicine, there is probably a high prevalence of anxiety and depression in these patients. And if these data are true, then we can take the experience back to the bedside. Now, the preliminary research was done in 3 major databases, one domain being the pancreatitis part, the other one is all the mental health relevant keywords. We ended up with 45 relevant studies, and I'd like to sum up my research as the following. We already finished with the prevalences and the smoking-related data, and we are still waiting for the questionnaire scores. But I'd like for you to present the newer findings compared to the previous progress reports. And if you look at the prevalence of anxiety in patients with pancreatitis, I'd like you to focus on 2 numbers. The first one is for CP, and the other one's for AP. If you look at the CP population, the number is 32, mark that number, and the same for AP is 25%. But if I move from anxiety to depression, then in the CP population it's more than 40%, and in AP it's 30%. So basically, if patients go to our hospitals, right now as we speak, at admission, they have such prevalences. Now, you can ask the question, how many psychologists work in these wards? Not many. So what we are trying to do is to provide psychological support for those people who are at this risk population. And of course, some studies didn't specify whether it's anxiety and depression, so we had to analyze anxiety and depression, anxiety or depression, but the overall numbers are similar. So we can analyze these data from the perspective of how heterogeneous the data are, and I will talk about it later. There's a huge difference in the definition of these studies. What's called depression, what's called anxiety. You would think that it's straightforward, but sometimes it's just a symptom, sometimes a proper disorder like major depressive disorder, and it's not the same. And it's usually not really reported. So the first draft is ready, and as soon as we have the final results from the questionnaire scores, we'll update the draft and we can move forward. As I mentioned, one limitation is that there's a high heterogeneity. The other one is significant differences in the outcome definition, influencing our interpretations. And there's differences in the AP-CP severity. Etiology is rarely reported as this is the depression anxiety for example, alcoholic pancreatitis, and this is for biliary, but they are just chunked together. And also there are no retrospective, there is nothing beyond retrospective designs with follow-ups, for example. But still, the strength is that there is a collection of studies now with assessment of different psychological constructs that influence pancreatitis, and we can conclude more stable medical conclusions based on this. As I mentioned, conclusions, let's talk about the implications for practice and the implications for research. The practice is quite straightforward. We need the revision of the guidelines. We need psychologists working in integrated pancreatic services to reduce these numbers that we've seen previously. And implication for research comes from the limitation part. We need prospective studies and intervention studies that GI psychology could probably offer in the future. Now, if you could move on to the second project, that's, as I mentioned, investigating the risk factors of psychological constructs on acute pancreatitis outcomes. Just a quick background. Again, we already know that mental disorders elevate the risk of adverse clinical outcomes. We know that. For example, if you look at patients with heart failure, you look at the attributable risk on the one hand, and on the other hand, the prevalence of depressive disorders, there's a clear linear connection. And just to repeat myself, there is no data like this for pancreatitis, which is quite a significant clinical question we need to tackle in order if we want to increase the quality of our patient care. So the aim would be the investigation of how psychological alterations may affect the clinical outcomes of pancreatitis. And this would result in a threefold question. I'm only focusing in our aims. In the first case, what is needed is the exploration of the dynamic change of the psychological variables during the acute phase. The second aim would be the exploration of the risk factors of the unfavorable psychological assessment scores. And the third one would be the investigation of how these psychological alterations may affect the clinical outcomes themselves. Just a few preliminary data that we have. On the first column, you can see the anxiety and depression scores at admission. It's very important to note this because these numbers are present before we did anything to the patient. It's not hospitalization, the effects of hospitalization. This is how they come in. And you can see that already 20% of them have clinical level of anxiety and depression. And of course, after we try to support them and try to psychoeducate them and so on and so forth, this number shrinks to around 13%. Now I'm talking about the clinical population here. And of course, this is just our award, so now we are expanding our reach using data from Székes Fehér and Pécs, where they do not have psychologists working at these awards, so that we can compare our data with theirs. The other one is the psychological scores and AP type. We have AP, recurring AP, early chronic pancreatitis, and acute on chronic pancreatitis. And if you look at this, again, the clinical part of the graph, there's a clear image here suggesting that it's not enough to focus on these psychological scores themselves, but this bidirectional plane between the psychological scores and their somatic descriptive factors, in this case, the type of their pancreatitis. Also, if you look at the etiology, I already told you some nuggets of information about this, but look at the data here. If we look at HDG, biliary pancreatitis, idiopathic pancreatitis, alcoholic, and so on and so forth, the connection is quite evident. If someone comes to our ward with an alcoholic pancreatitis, some sort of pancreatitis that has to do with tumor, we need to deal with them first. We need a triage system like we do at our ward because they already come to our clinic with these numbers. And also if you compare this to the VAS score, the visual analog scale and the hospital anxiety and depression scores, the evidence is not as clear-cut as on the other one, but the main message is something similar. It's not a linear connection like that in other inflammatory GI condition. There has to be some contributing factors resulting in these waves that you can see in the data. But if we don't see this, then we don't know what are the risk populations that next to painkillers needs to be augmented also by psychological interventions. And last but not least, we try to investigate the CRP levels and the psychological scores. In this case, we have the mild AP cases. They are fairly on one level. If we move on to the moderate AP, you can see that together they are a bit similar, but compared to the mild AP, they're a bit elevated. And when we arrive at severe AP, you can see this linear sort of connection. And of course, The more complicated the AP, the higher the CPR levels are. Well, it's not a surprise, but the fact that the psychological variables go almost hand in hand, especially if we focus on the abnormal levels of these alterations, then again, it's also an evidence that we need the revision of the guidelines, and psychologists need to be working at these units and not just be there when they are needed on call. And I'd like to leave my presentation with a quote of Ralph Waldo Emerson: please do not forget that the first wealth is health. And thank you for your kind attention.
Thank you very much. Any questions from the floor? Please.
So, as always, excellent presentation. I had a question from your first project. So you mentioned that there's a quite heterogeneous outcome definition. So what's your experience with this outcome definitions? I mean, in collecting, analyzing, pooling them?
Yeah, thank you for your question, because this is one of the greatest limitations. Again, if you contrast these data with that from cardiology, for example, those definitions are proper definitions, usually. It's written whether it's a major depressive episode, disorder, or a panic attack, and I could, list these conditions until the evening. But the point is that I know what I'm surrounded with. It's not like anxiety symptoms and depressive symptoms like what we usually have here, but these are clear-cut definitions supported by the DSM or the WHO. And if you compare these, well, the problem is that of interpretations. We're having many meetings about this, because if I do not really know the definition, that I, as a clinical psychologist, I'm like, I need more data. I need more data to plan the psychological counseling. I need more data whether maybe this patient needs to be sent to a different care facility. I need more information whether to plan his or her health behavioral support. So this could be imagined, and this is my interpretation of these results so far. This is kilometer stone number 0. We have to have these GI psychological results, but then we really need to move on. We need clear definitions in order to have better clinical outcomes. And also, as I mentioned, we need intervention studies, because it's fine to have prevalences, but then we want to reduce these prevalences. Thank you for your question.
Thank you.
Thank you. Anyone?
Congratulations, Tibor. We could see from your second study that there is also an improvement in the hospital by receiving the psychological interventions. Do you have any long-term experience, or are you planning to call these patients back and give additional psychological interventions?
Mm-hmm. Yes, we also have a different study at our ward, the Reappear study, which basically focuses on alcoholic AP. And we see, and now this is a very rudimentary description of our results, but those patients who do not really have severe personality alterations, personality disorders, let's put it this way, they usually do come back. And their problems could be reduced by psychoeducation, simple, or I should say more simple psychological interventions, so not psychotherapy per se. And they can indeed reduce their drinking and their smoking and everything that has to do with their pancreatitis. On the other hand, those patients who have other comorbid conditions, and I'm not talking about somatic comorbidities, but psychological, psychiatric comorbidities, it's much harder to work with them because this intervention is not really suited for them. So when we are devising an intervention study based on this, we have to look at this. In a psychological sense, this population is not homogeneous. From a somatic part, yes, but it's like two different axes. We need to divide these somatically homogeneous populations into different personality structure groups, if I may put it this way, and those who are on one end of the spectrum and who are on the other part of the spectrum simply need different psychological interventions.
Thank you, Tibor.
Thank you.